Well, hey guys, welcome to the September edition of SWAC here. This is entitled LAAC with a Twist. We've got some great cases to show. We're joined by Devi, Nair, and Saibal, two world-renowned experts in left atrial appendage closure, and really excited to have them moderating some of these cases. Just a reminder for everybody, we are recording this, and we'll make this available on the MurmurMD social media platform and the socials. If you're joining via a mobile phone, please type your name and email into the chat so we can get you on our listserv and invite you to future SWAC meetings. So without further ado, I'll pull up my screen and we will present the first cases. So it's LAC with a twist. And so these are, I think these days Watchman is, or LAC, I should say, is really 95% of cases are pretty straightforward, but 5% of cases remain kind of challenging. And sometimes that's related to the transseptal puncture. So I've got a couple cases that I had. So again, my name's Joe Walsh. I'm an interventional cardiologist, structural heart doc out of Boise. And we'll be talking LAC with a twist. So first case I've got here is an 83-year-old woman referred for left atrial appendage closure. She had a prior MitraClip for functional MR. And due to bidirectional shunting at the time of MitraClip, we decided to place a 25 millimeter cardioform. We don't typically do this. It's pretty rare, but we were concerned about this patient, had some TR. We're worried that she was going to get hypoxemic. So we placed a 25 millimeter cardioform, and then she had some GI bleeding with a contraindication of long-term DOAC. So we decided to proceed with LAC. And I just want to remind everybody, all these cases we post on MurmurMD as well, which you can access via the app. This is just kind of a illustration of the case that was posted that I'm presenting today, as well as our Optimized LAC channel, which has all the discussion, the clinical resources, and videos. So if you don't have that, we'll have an invite at the end of the presentation. So I just want to talk a little bit about septal occluders. I guess the question is always, do you go around them or do you go through them? Fortunately, this patient was a MitraClip, so we did have a little space inferiorly to go around the device. And I looked at the literature on this, and Devi, I'd love to get your opinion on this, but there was one really nice EP study where they looked at about 70 patients, and if they could go around the device, they started with that technique, and if they couldn't, they went through it. And it was pretty dramatic how much shorter the procedural time was when you went around the device. So in general, my approach is if I can go around the device, I'll do that. If I can't find a window around the device, I'll try to go through it. And most of these occluders you can go through. But Devi, you do this all the time because you're doing ablations. You're crossing septums all the time for ablations. What's your approach to septal occluders when you have a patient that you need to ablate? I'm just curious.
Yeah, I mean, so you said it right, Joe. It's just going around it is always obviously the most easiest thing, and most of the time we get lucky with these occluders that there's always an inferior rim, and majority of the time for most of our procedures you can get away with an inferior stick, and so that inferior mid, inferior posterior area we can get in. Rarely we'll actually go through the inferior anterior limbus, so that thicker portion. You just have to be careful with AV node when you're going through that portion, but we routinely will go through that thicker limbus, the inferior limbus as well, before we actually decide on going through the device. I think going through the device is like the last option for us most of the time. If you have the details of the device available, like you said, every device is different to go through. So depending on the type of device, you have to pull out your tool set most of the time. So.
Yeah. Saibal, Aidan, what about you guys? What's your approach?
I've done the same thing. The few cases that I've done, I haven't done too many. I've done most of my cases. Oh, there's two cases actually. I pulled out the device, went in and did a procedure, and then put a new device in. I've done that.
Nice.
Snared out the Gore device, and then it was a Gore device. Snared it out, pulled it, and went out. But most of them I've done on the posterior side because usually, if it's a PFO device, usually you do have a space posterior inferiorly. Okay. And saying that, I just want to mention about one other device which I don't know whether you guys have heard. It's called the At-Heart device. Have you heard of the At-Heart ASD device? It's a device.
No.
No.
It's an ASD occluder, which I'm the national PI. It's a ASD occluder, which is Dacron patch bilaterally, but the framework is not metallic; it's polymer, and it's made for ASD occluders, and it's going to be used for iatrogenic ASDs too. and there's a study going on
I love
right
that.
now. So what it does is you can deploy the device, and it goes up from 8 millimeters to 19 millimeter ASDs. And once you occlude the device in 3 years, the framework will dissolve completely, get resolved, and all that you're left will be the dacron patch and the tissue.
Oh, that's
Yeah.
very elegant. I love that.
Yeah.
Yeah.
Yeah, and this is this is an annoying problem. We're doing a lot of left atrial work now, and this is kind of, I think, going to become more common. So I think it's important to have an approach and have kind of a procedural strategy when you're approaching these cases. So my procedural considerations when I know I have an ASD occluder and I've got to do a left atrial procedure, I don't think it's wrong to get pre-procedure CT planning. There is a role for ICE if the TE imaging is not optimal. I always put in a 16 French sheath up front for these cases because I know I'll probably be doing some sheath exchanges and I don't have to deal with that. You don't want to have your staff going to find the septostomy balloons, so have some balloons handy in the lab. And then I personally, for these cases, when I'm crossing around an occluder, I think the VersaCross is probably better than using the VersaConnect. I don't like to do the whole big 14 French sheath to cross the septum. I think you get a little more precision with the VersaCross. And if you have a long balloon shaft, I think it's important to use the MitraClip wire that comes with that because you'll run out of room on the wire if you're going to do a septostomy. And then lastly, I always get nervous dragging my transseptal sheath down when you have an ASD occluder, especially the Gore device. You can really mess up some of the nitinol. And so I'll usually try to get the Baylis, curve and just put it right at the inferior border of the device and then push my transseptal sheath up instead of doing that. So Devi, Saibal, Aidan, do you guys have anything that you would disagree with this or something that you would add to it if you're going to go around these?
No,
So I'll jump in. I'll say steerable sheet definitely for sure because I use Baylis 100% of my cases, and I'll definitely say that steerable VersaCross would be my choice because I want precision. I don't want to drag. And the advantage in my mind, I absolutely love the way you do it as well with going inferiorly rather than doing the drag
Yeah.
down from the SVC. That is really the way that we would do this as well. With the VersaCross loop, I think it's safer to do it.
Yeah.
Before, I would say it would be harder. There is Saibal, what's the name of Bridges device that has a little bumper balloon? I'm talking about the transseptal sheet that has a little bumper balloon.
Safe
Cross. Safe Cross. Yeah, it's just like this. Yeah, it's got a little bumper balloon that comes from that you can kind of, for difficult cases, I have used that. I'll come from inferiorly and kind of bump off just to stay away from the Go device. But otherwise, I completely agree on this. I have to check out this MitraClip wire business. I don't know what that is. I just use a stiff
MitraClip guide. MitraClip guide is very good. Even you, no.
No, the wire. It's got a longer wire.
The Watchman wire that comes with the VersaCross is shorter. I think it's 180. And the MitraClip one is 230. And we tend to use these long shaft balloons that are like 135 something.
It comes with the VersaCross, the long wire?
Yeah, there's a long one and a short one. Right, Yeah.
Yeah, I asked him to get rid of all the short ones and just stock the long ones because this has happened before during cases, and then you don't have enough to reach for septostomy. So we try not to keep any of those. I think some of the EPs still keep some, but I've gone to all the longer wires.
Are you talking about the longer wire for the VersaCross? Is that what you're talking about? Right. Oh, okay. Yeah. I mean, we get rid of all the short wires too.
Yeah,
because every once in a while you need to do a septostomy or something, and then you're on this short wire. And it's, But we just get rid of those, and I think that helps. I don't know about you guys, but I've found it really tough to visualize just the transseptal needle on some of these cases. I've had success going through a Gore device. We did have to abort one a while ago. It was an Amplatzer device, and I just couldn't see the transseptal at all. And at the time we weren't doing much ICE, so I think ICE might be another thing to consider on these cases too.
Yeah.
So unlike you two of you guys, we are a small community poor hospital. We can't afford expensive things like VersaCross and steerable VersaCross. So we use an old thing called a BRK needle and a sheath. And if that's not available, we use a coat hanger.
I love it. So this patient got on the table, and this is their kind of 4 views on the TEE, and I think this is a good opportunity to just take a second. And I'm just curious for Devi and Saibal, when you guys are sitting with your imager prior to Watchman procedures or amulet procedures or LAC procedures in general, and you're looking through your TE, what are you using in terms of the views, in terms of planning your transeptal? I was hoping one of you guys could just take us through your process when you're sitting with your imager and looking at your 4 views and trying to understand where you're going to stick, and then a deployment strategy. Could you guys walk through perhaps just like this one and talk about what your approach is? Either one.
Yeah. So, so I think the key is, I mean, you have great images that you're showing here. I mean, and they're still images, but I think it's important to scan from 0 all the way to 180 to see where those, what that 135 is. It's not always a 135, as said. It might be 130, it might be 140. So just scanning through to see where you see the ostium widest and the ostium is at its narrowest point is important. I think it's also important to assess the collateral structures. To me, that 135, that high angle is what tells me where the PA is. So helps me analyze, how I'm going to deploy the device, especially the choice of the device becomes a thing at that point. Am I using a Watchman? Am I using an amulet? Especially with the PA proximity. I'll look at the mitral valve, or the pulmonary vein ridge. So these are some of the things I look at, but mainly in my mind, I'm looking at the orientation of the main axis of the appendage, within about 10 to 15 millimeters from the ostium. That's how I look at it now with the flex device. And if that axis is more anterior, like you're showing in this one, I'm usually into an inferior mid stick. That is my go-to. It's very rare that I stick away from inferior. It's almost always inferior, except when that high angle shows me a nice posterior curve. Like if it's hugging the LV and coming down towards the LV, then my stick is higher. I'll go for a mid or a mid posterior stick at that point. But otherwise, it's usually an inferior posterior stick or a mid stick. Now, very rarely, if I have patients that have huge left atria, like very large left atrium, they're in permanent AF, and they have a very, very acute anterior chicken wing, I will come for a very low inferior anterior stick. That's my only time I go for a nice low inferior anterior stick. So that's kind of my go-to sticks.
I love that. Yeah, so for this appendage, I thought, an inferior stick would be fine given some of the anterior trajectory. And that worked out because the occluder was below. So to Aidan's point, it is really hard to see your tenting. And so I put the arrow there for those who couldn't tell. You want to make double sure that you know where that needle is before you go through. But I felt like this was just at the infraposterior ridge of the cardioform device, and felt comfortable that we could go around. So we went ahead and punctured there. We got our stiff wire up in the PA, and then performed our septostomy with an 8mm balloon. This is the live TE images of the septostomy. And this is something a lot of interventional and EP docs don't know. There's actually a CPT code for septostomy. It's 33741. And you actually get 22 RVUs for that. So if you're doing a septostomy as an add-on for a procedure, this is a code you can use to bill for, given the extra labor involved with it. I've used this, and it's been helpful. We use this for ECMO a lot. We do septostomies for that. So 8mm balloon. This is the setup shot. Again, I've just got my flex ball in the anterior lobe of the appendage. Looks pretty straightforward. And then a nice deployment. This was prior to having true steer, but wasn't needed in this case. So we had a good result with this patient. And again, I think if you can go around it. And I think we talked about some of those procedural considerations. And then this is just the final images in a biplane, 45 and 135. And then I've really taken, I don't know if you guys are doing this too with our TE cases, I really like seeing the 3D, and I really like seeing that kind of, Shafel Doshi calls it the muffin top, and I think we've really kind of shifted the paradigm where as opposed to being completely flush with the ostium, I like seeing that little muffin top on 3D as kind of an endpoint for the procedure. Are you guys using 3D, or do you find that helpful for these procedures in terms of assessing your end result?
Actually, I don't even do measurements in the 4 angles. I actually use it by MPR. I do the whole thing by MPR. I just do
That's
views,
great.
And with MPR, I wish I could show you. I can exactly take one picture and then go offline, and then I can measure everything. So I don't.
I love that.
I think, I think 3D should be the gold standard for imaging for
Or for
appendage
any,
closure at this
for that
point.
matter, any now transcatheter procedure, we do a lot of 3D and MPR. We use MPR very much. For,
Devi, are you using NPR as well?
Yes. So we'll do the slicing at what level we need, and then go down to the MPR, and clearly it tells you, how oval your appendage is or how off shape it is. It's very rare to find a round appendage.
I love that.
one more
Yep.
point. Actually, it was the point that was brought earlier about where you should do your transeptal puncture, and you said what views. I want to point out to this case at the 90-degree view. Go to that picture. I like that picture.
Yeah, I'll go back. Yeah, and I think this is really helpful, Saibal. I'd love for you to walk us through your process because Doug Gibson did a great talk on this, and I haven't been able to find it. But I think this is something important that every
So when
watchman
you
or,
see,
or
I
LAC.
start with the 90-degree view, and at the tip, and this actually Devi also mentioned it. When you see the tip of the appendage is in the same direction as the ventricle, then this appendage is thus horizontal or low die. If the tip of the appendage is away from the ventricle, right, then that's a superior takeoff appendage. And those are the difficult ones. And that can be seen also in 135. And the same thing is if you do 0-degree, look at the appendage, how this is curving anteriorly versus going laterally. So just taking these two views, I decide where to do a transeptal. So if I see an appendage which is looking towards the ventricle, as in this case, then you don't have to be super low, as Debbie said. You can be mid fossa, this thing it'll go in. On the other hand, if this appendage was looking away from the apex of the ventricle, that means this is a superior directed one. Those you definitely have to be very inferior in your puncture. You're going to go right.
Yeah, I totally agree.
So I use that 90-degree
and even true steer
to give you an idea.
Even true steer, I feel like is hard to make up for a poor transeptal in those superiorly directed ones.
Yes.
In my experience, you still need a good.
You still
stick.
need a good, yeah, exactly. But true steer helps you better because you can put it up, but you still need a good punch.
Yeah.
So let me ask you guys a question about this closure devices and them going through this. So, obviously somebody put a closure device there because there was a hole, and now you've created a hole. Have you guys looked at if these transeptals that we create around these devices close up? I mean, I know for EP studies and for ablations, when we come back for appendage closure, 90% of them we have to stick again. We have to actually go transeptal again. But what do you know the data on that? I mean, is there concern that you have to close it on the way out?
I think the data is 75% of them end up closing spontaneously, and then 25%. I think this is MitraClip data, and Saibal, correct me if I'm wrong, but my understanding is about 75% of them close spontaneously, and then 25% remain open. And those are probably usually patients with chronically elevated left atrial pressures.
I'm talking about people who already have closure devices, and now you're going.
Oh, now you're going, yeah. If you're going through the device, I don't know that. That's a good question,
Debbie. Those will not close right away because you're actually piercing the membrane. You're stretching it out. I think the natural history of those holes are different from just going through a natural septum.
Yeah. Sometimes I get a question on, what do you do? Do you close it again?
Yeah, I doubt there's any real good data on that because I don't think anyone's doing a whole lot of these, but it's a great question.
Awesome. Well, I got one more case that's quick. Zach, any questions in the chat that we can address before we move on to the next case? No? Okay.
I think you're good. Yeah, go ahead.
Cool. This is just a quick one. This was actually a month or two ago. An 82-year-old prior subdural hemorrhage was traumatic, referred for Watchman, and get the patient on the table. And we had kind of a new imager who was new to Watchman, and they couldn't get a 135. I'm not sure why. I didn't really push it. So we just had these three views, and to Saibal's point, and Debbie's point, the 135 is just so key to understand, your trajectory of the transeptal puncture, which lobe you're going to try to deploy it in. So I was flying a little blind, and I decided to rely on my angio. As an interventional cardiologist, I always take an angio for my left atrial appendage cases. I really like using angio, but I do think it's important to co-register it with TE. So didn't have a 135. I get in on the day of the procedure, and I take this picture. and there's clearly a posterior lobe. I felt like there was probably an anterior lobe that I couldn't get in, but despite, manipulating the device and the ball and trying to get in a different lobe, I really couldn't get in any other lobe. And obviously this posterior lobe was too small for me to get the device in, and it wasn't a super favorable angle. Any thoughts on this angio? What do you guys think of this angio?
So, by the way, starting with the first thing, that you could not get 135. So it can happen. That's the advantage of MPR. If you get one view with MPR, you'll get all views, right? You do an angle and you do a 3D, you'll get all the views. Or you get the 45, which is the easiest to get anyway, and you put the line through the 45 and you'll get the 135. So I tell people, don't worry if you can't get 135, you'll get it. Just get a 45 and explain it. So that's one thing I'm just okay. And this seems to be okay. I mean, you go back to the previous view picture. I'll show you something on the T. Do you see how this apex of this appendage is looking towards the ventricle? Right? This is what I was saying. So that means when you see the apex of the appendage is pointing towards the ventricle, then this appendage is looking this way. This is the heart, right? Because think of it, the heart is like that, right? So it's looking downwards as horizontal. If it was away, it would be looking up. So I think that's one big lobe, and I think you're in the right direction. You could have clockwise and gone a little bit more deeper if you wanted to.
Well, yeah, despite
I do think that. I was just going to say that I do think the posterior windsocks in the non-steerable days was the hardest one to do, in my mind, because the device tends to just bend on you. I have to say that they have become much easier with the steerable sheets, though.
Yeah, and it makes those posterior windsocks so easy. So I failed at this. I wasn't able to get a device in, and so I decided what our typical routine is. We don't get pre-CTs on these patients, but for these patients where we fail, we're not able to get it in. I decided to do a CT in this patient, and it was remarkably helpful. The 3D recon didn't really show it, but there's where the arrow is, there was a very long, fairly thin posterior lobe that I think my Watchman ball kept finding. But there's clearly a very favorable anterior lobe here that I wasn't able to get in, that had a septated kind of rim. And so my device was just subselecting the posterior lobe. But in reality, there was actually a really nice anterior lobe I hadn't even seen, because we never got a 135. And again, this taught me a lesson is, use multiple modalities to understand where you're going to deploy these devices. So this is an RAO caudal view. So I took the patient back. We had true steer at that point. I did a more inferior stick because I was trying to get in that anterior lobe and mid. And true steer was very helpful. I did superior deflection, and then I did mid deployment steering, where I deflected the device inferiorly as I put a little counter on it to come out. And so had a really nice result with this. But again, this really taught me, the 135 view is so critical for planning and deployment. Definitely going to look at 3D MPR based on your guys' recommendations now. We use it for MitraClip, but not for Watchman yet. And then really, I think every failure, you learn so much from getting a CT if you haven't already gotten one. And then I've been using TrueSteer in every case because I really don't know when I'm going to need it. And I feel like it's worth the price point. So that's my takeaway from this. Just kind of a quick lessons learned case. I don't know. Any thoughts on that, guys?
Yeah, man, I think I'm a steerable sheet person too now. Since I got the steerable sheet, I'm like, I don't want to change sheets. I don't want to change devices. And I don't know. I mean, there are going to be challenging cases where you need it. And then what I've also seen is that my regular implants, I think I do a much better job now, because I can optimize it so much better. Like, I don't have core wire bias. I get to play with it quite a bit. So I do think that, yes, it is a little bit more expensive, but it is worth the price, especially in this era that we are talking about how every leak matters, and we're trying to have the most optimal implant. I feel like it's got a value, and I'm 100% steerable sheet person.
I love it.
But I'm also an EP, right?
Devi, I use a lot of steerable sheet for parallel leaks. Devi, the thing is that, I'm a single curve sheet person. You know that. 97%
I know. I know.
I've heard that about you.
Yeah, it's ridiculous.
Yeah.
The 1% single curve sheet used in the US.
Yeah, exactly.
Everyone, anytime you mention a single curve, everyone's like, "That's the only one Saibal uses." I don't understand.
And actually, you'll be surprised that single curve sheets are actually good for the ones which are appendages look down. Like
Yep,
the
that's
one
yes,
case
I
where
agree.
a double curve sheath is not helpful, because if you take a double curve sheath and you counterclockwise, the tip looks upwards. But if you have a single curve sheath,
Yeah.
if you clockwise it, it just goes posterior. So this is one case where a single curve sheath has some advantage. But otherwise, I
Absolutely.
don't think I agree with you. And the other reason why I use single, I know people laugh at me, and Boston keeps on telling me, "Don't teach this. Please don't teach this to anybody," is because when you use a double curve sheet like this, right? It's a double curve. When you put the device into the double curve sheet, it straightens out anyway. So you lose that anterior curve anyway.
It's a very good point.
That's why
Yeah.
I used to stick very posterior and not use it. But unfortunately, the true steer is a double curve sheet with a this thing. It's not a single curve that goes up and down, but that's fine. I don't report it.
And it doesn't straighten out anymore because it's got so much
Yes.
more robustness that when you put the device in the true steer, it stays in that double curve pattern. But you can't steer down and make it a single curve. Just pre-steer and go in, Saibal. That's what I would do.
Yeah, I love it.
I like it.
All right, Rayman, you wanna do the next one?
Real quick, I did put this on screen, but in case you didn't see, there was a question that said, would ICE
Yes, I
have
saw
helped
that.
you in the first
Well,
try?
that's the
Just want to
question.
make sure you're aware.
In the first case, to see the device, you mean do the transeptal? Caleb, is
Yeah,
that
I think the second one.
Caleb, you want to follow up that? I see your question, buddy. Would ICE have helped you in the first try? Oh, I think he was saying the first,
First-
the
So you okay?
the one I
think?
failed. The one I failed.
Yeah,
that would
yeah.
help. But
I mean, it depends on what ice and how your ice uses, right? Where if you're putting the ice in the left atrium, and if it's some kind of three-dimensional ice, maybe, but otherwise, there's limitations to the views that you see on ice too.
But I agree with Saibal.
Could have helped for sure.
I think an NPR and then just go through the 45 to get that view. Probably you would have been able to get a 135.
I think by explaining like Saibal said, the 45 is the way I would go. If
I
you
just
can't
do
see
two
it.
views and I explain the other one. And now with NPR, you don't even need one. You just need one view and you can get all the angles.
no, I love that. I'm definitely going to
Yeah,
try
you
that.
can just
That's a great
do
idea.
one view, do full volume, then you save it on the other screen, and then do MPR, and then just whatever you want.
I love it. All right, Aidan, you want to do the next one, bud? I think Zach, is Tom's fellow on? He had some of those IJ cases.
I have not seen him yet, but I will message him again.
Okay, cool. All right, Rainey, you want to pull up yours? I gotta return this call real quick. I'm on STEMI call, so I just gotta make sure it's not a STEMI.
Perfect. Share my screen. All right, so I'm going to go straight to the images on this case. Can you guys? Let me see. Oh. Hang on one sec. How do I start over? This will take forever. Go up here. And start the presentation. Okay, so I don't have the true steer yet. In fact, nobody in the whole Providence system does. We've been trying to get it for the past couple months, but I'm curious what your guys' thoughts are on this case. This is a case from Monday that we did, and so basically here's the 0 degree, and basically there's just a big turn on this appendage in almost all the views. Here's the 45. You can see it flexes back and goes anterior. I think this is going to just play for a little while. There's a measurement there.
So this is going, and this is going downwards. This appendage, right, down and anterior.
Yeah.
But also you have to get into the appendage here. Let me show you one more view, and then you guys can kind of comment on like how you would approach this just via Transseptal. And these are the measurements. So really good, depth there, but it just makes this very sharp turn. Definitely a twist on this left atrial appendage. And here's the 135 view. And again, it's kind of diving posterior. You have to come in this way and then make this turn. So, Saibal, thoughts? How would you approach this just in terms of transseptal?
Transseptal puncture, I won't do very low. I'll do mid fossa and posteriorly directed because it's going downwards. And I don't think the sheath can go right down that curve. You can't. So what you need to do is deploy the device more proximally in the limb. You cannot go right around that curve. It's shoe sharp. You have to angle it slightly more superior and cover this area. I wish you could show my arrow. You can't see my arrow. But I don't think you can go inside like that deep. You can't get a curve like this down. You would actually just go to the shoulder here, a little bit down, and then angle it.
Got it. Devi, any thoughts for you here?
Now, I definitely agree on the kind of the mid-posterior transseptal for sure. I think this is definitely, you don't want to come too high because it also has a accumbendant ridge that's going to prevent you from, so you want to kind of stay. This is when I would actually tent it, and then I would have my imager show me the appendage and the tenting in the same view. So I can see that my tenting is pointing under the ridge because you don't want to ride too high.
I wouldn't go high.
For that.
I'd go mid fossa or lowish, but it's still posterior puncture.
Still posterior, agree. And then this is one day, one time I actually would say that I am so thankful for a steerable sheath.
Yeah. Right. So we didn't have a steerable sheath. That's sort of kind of what, we wanted the discussion to be around for this case. But at any rate.
In one sec. So Devi, can you talk about that? So, because we do that for clip and I find it really helpful. Is it live 3D where you look at the tenting and the appendage? Is that how you do it?
Yeah, so live 3D, and then you watch the tenting and you make sure your tenting is aiming, it's not too super high or low. I mean, you won't get your anterior posterior axis, but you can definitely see the superior inferior axis on that live 3D.
Okay.
And to me, that's like the best way to know that you're not super high. And I usually do that anytime I go mid, and I want to assess the horizontal, the height of my transseptal. That I go live 3D.
Got it.
You should not be too posterior in this puncture. If you do too posterior, you'll hit the accumbendant ridge. You'll have to be in the mid fossa in this posterior, and then and of course, single curve sheath. Sorry to say that, but
it is single curve sheath. I mean, if you don't have a non-steerable, I think single curve is the only one I'll try to use. But like Saibal said, I don't think the device will bend. But the beauty of Flex in my mind is that it does bend in a sense. That's how we used to do it. Put that ball and make it bend and go down because it's going to bounce off that back wall and try to slip in. But the biggest concern is, leaving a shoulder.
But Debbie, you agree that I know you're right. The device, if you push it in, you do a push pull, you'll actually go in down. But I don't want people to advance the sheet deep inside. You can end up lacerating the appendage. Going on these curves.
Yep. Oh, this is just showing that it's nice to do a drive-by. This is how you can get a couple MitraClip cases. So this patient had ended up having severe MR, and so I was just going to play here.
Raney, have you? Because I do this.
I get the MurmurMD thing now.
And we've got reversals in all the veins. So
Raney, I've done this a lot. Where on my MitraClip patients, I do the Watchman first so that I can get a nice TEE at the same time.
Yep.
But someone's been Tom was saying actually that if you do a Watchman and then you do a clip, there's a higher rate of DRT. Does anybody know that? Because you're taking away that washout from the mitral regurgitation. Have Saibal or Aidan, have you guys noticed that on any of your clips? No,
I haven't seen it, but it makes sense.
Is the problem. I thought mitral regurg is the problem. If you have a jet headed towards the device, you don't get proper endothelialization.
Well, we'll actually see when you put a clip on. Sometimes you start seeing smoke in the left atrium because the flow is a little more stagnant without that jet. I don't know. It's just
I mean, do you mean doing a Watchman followed by a MitraClip?
Yeah, Watchman
Before.
and MitraClip when they're when you've done a
I
fresh
think I've only
Watchman.
done it once. I don't do them together, not because I can't do them, but I just, for financial reasons, I don't do it. I'm telling you, I'm not a rich hospital like you can afford all these things.
So yeah, I'll just head on with this case. So basically, this is just kind of an AP shot trying to get into this appendage, and we did end up going somewhat inferior and mid and a little bit inferior, and it was hard almost to get in. You can see here, and I'm kind of glad that we went inferior because I think if we didn't, we wouldn't be able to get into the appendage here. And I think if we were more superior, we'd be up here hitting the ridge. So I think the inferior basically helped us here. And this is my first deployment, which I thought was probably going to be pretty reasonable. And then, sorry, this is not presenting very well. But you can see even when I pull back to do a tug, now I'm actually outside of the appendage.
Yeah, that's a bad feeling. I never liked that feeling.
Yeah, this is not a real comfortable thing here because now, and I'll show you some of the imaging here. And here's another view. And you can see that in these planes, we're actually outside of the appendage ejecting, and we've kind of fallen out.
It looks a little deep, Rain. I might come more proximal.
So this is what we found on the TE. So there's a fairly large shoulder here on the 135.
Oh, yeah.
It actually looked like there was some flow between the device and the edge of the appendage.
So you see, that's why I would have preferred it to be not going inside like that. I would have preferred it to go more like 5 o'clock, 4 o'clock position. Then that shoulder would be tucked in, and the sheath wouldn't have to go so deep. Do you know what I'm saying? Like you've gone in like that, I would have been more angled.
Yeah, and we were pretty vertical when we deployed this the first time.
So, Ray, I'm trying to understand what I'm looking. So the device is in that posterior lobe, and then there's another lobe.
Oh, it's on the way in here, right? Here's the appendage down here.
Is that the real ostium, though?
I think it just takes like a loop and a big bend, and I think this is the pectinate down here, and this is this whole area here.
I would have deployed the device completely different. Like, see here, your face of your device is like 3 and 9, correct? I would have deployed the device where the face of the device would be 7 o'clock, 2 o'clock, and that direction. Then you would cover the whole.
And had it going up this direction. So basically what we ended up doing is then we pushed it in here, and it was one of those where it was just sort of like a bank shot with the ball. And, I don't think it's really a super reliable because sometimes that can get kind of hung up in the pectinate. And actually here, it looked like it was too deep. And this shoulder here was tucked under here. So we did one more partial and then deployed it again. And this actually looked really good. It was fairly snug in all the views.
Okay, now I see. So that's just the Coumadin ridge wrapping around the top of the appendage.
Yeah, wrapping around,
Yeah, all right.
Yeah, this is a nice deployment.
Got it.
But kind of, and so, we don't have access to the steerable sheath, and there is an extra cost associated with it. So we're actually trying to come up with some criteria, when to use it and to use it on every case. But, on this case, I'm curious, with you guys with some experience, what's your thought here? Do you think it would have helped to have a steerable sheath here?
You did a good job. You did a nice job in this case.
Yeah, that's a great result rating.
Yeah, that is definitely that's the most you're going to get out of this appendage, even if you use a steerable. So, but maybe it would have taken a little bit of pain away. That's all. That's about it. I think this is a tough one, Jace, because of that long Coumadin ridge that hangs over and prevents you from doing anything. So I think in my mind, it's just the only thing the steerable sheet does is it allows you to have a little more precise deployment and have that midway steering, or mid-deployment steering. And, you would probably extend as you come out, and that might help. But I mean, either way, I think you did a great job. I mean, that's a pretty good implant.
Devi, can you talk about mid-deployment? Because, I've done maybe 20 or 30 cases with the TruSteer, and I feel like I'm still getting used to the mid-deployment steering because I was trying to do it kind of slow at first, and then I realized it kind of works better if you do it fast, like you're pushing the device and steering at the same time. Like just in terms of the haptics in your hands when you're doing the mid-deployment steering, can you talk about that?
So, I mean, the two times that it actually really works is if you have a nice acute anterior wing or anterior appendage or a nice acute posterior appendage. Your regular windsocks, you don't really have to do a lot of mid-deployment steering. And it works almost, it's counterintuitive. If it's anterior, you get that ball right up into the anterior lobe. And the way I do it is I actually withdraw my sheet. So I try to pull with my right hand. I pull the sheet back. I unsheath with some forward force on the back. And then with my left hand, I steer. So I'll flex down. So if it's an anterior or anterior wing, and as I'm unsheathing with my right hand, I flex down with my left hand. So as you flex, you kind of, it's almost like backing off a Jeep or something like that. So you just kind of get that back in. The same way, if I'm doing a posterior, like this particular case, I'll initially start off with the ball configuration. I'll flex the sheet, get into that lobe. I mean, I wouldn't go super deep, but I'll get into where my orientation needs to be. And as I'm pushing out, same way, I push with my right hand with control. Like I push and unsheath, but then I will extend for a posterior windsock and make it rise up is how I'd put it.
Yeah, and I think that's the thing that's important. You have to do them at the same time, right? Because if you try to steer and then deploy, steer and then deploy, it just falls out. But I found you have to do them at the exact same time. You have to be steering while you're deploying, and that tends to work really well.
Right? You're talking about the anterior chicken.
So the anterior or posterior, either like this case, I would do an extension on the thing on the steerable T. So your sheath is sitting that way, and you deploy the ball, and then as you're coming up, you extend up. It just kind of pushes it, and you don't get that superior leak and things like that. But
yeah, I love it.
It is stiff. It is bigger. It costs more. It has its own issues, but I think to me it's a predictability thing now, and I've just gotten used to it. So
yeah.
Do you use it every case, Devi?
I use it for every case. I mean, I justify the value for every case because I feel like I don't do that many recaptures, which with Watchman is that's not that big of a deal. But you think about a patient that has, this sludge and smoke, and you deploy the Watchman once, you see stuff forming behind the device right away. And, you're almost against time there. And so I still like to have one deployment if possible. And I like to assess my angiograms because even in that case, as you were doing it, you saw how much core wire bias you had. Like you were outside of the appendage, and it was, then trying to go back in there is just like painful. So
really painful. I think even just for to get back in there, it would have been really nice to have a.
I have to say the reason I started doing in every case to begin with was, I said, I got to get good at the steerable sheet in good cases before something bad comes in because I don't need bad and bad. So that's how I started doing it for every case, and then I was like, oh, I don't want to go back anymore. So and it just turned out that way.
You get used to something.
You get used to it.
Can I show one,
yeah,
please?
it's just a lot.
Yeah,
you don't mind,
please.
Oh, I love it.
So how do I share a screen?
If you go to the bottom, it says share, and then you can just share screen. If you have it pulled up, you can click on it.
So this one, share. Okay, yeah, screen.
Yep.
I'm gonna go to screen.
Yep. Say screen, and then it'll show you everything.
Entire screen. We'll just share the whole
window, and then click on this. Can you see anything now?
Not yet.
I'm sharing it. What's it doing? One minute. Let me see the slideshow. Current slide. Yeah. Okay. Wait a second. Where did I go? Share screen, right? And if I click on it, it doesn't work. It should work, right? Why isn't it doing this? Oh shoot!
You could try entire screen, and that might work.
Do entire screen?
Yeah, try that.
Share. Okay, stop.
There we go.
You can
Here we
see it
go.
now?
Yep.
Yep.
Okay, sorry. So this, can you see it now? Yes. All right. So
Yes.
this is the, anyway, so this is a 76-year-old gentleman from Fresno. Caleb Thompson was taking care of the patient. No, I'm just joking. He had cirrhosis of the liver, GI bleed, AFib, underwent appendage closure by a watchman in April. Apparently, he was on diuretics, which he stopped, and then he presented on the 26th, which is 2 weeks in the emergency department, with severe shortness of breath, increased abdominal distension, and leg edema. But he already had all of this, but now he was really short of breath. So he comes to the hospital, and they do as usual. They don't examine the patient. They do a CT of the chest. And what do you see in this?
Oh, I don't think we just.
Can you
Oh
go to
yeah.
slideshow?
So basically, he's an alcoholic cirrhosis, GI bleed, AFib, has an appendage closure on April 9th. And then his diuretics were apparently stopped or reduced, but he presents 2 weeks later in the emergency with severe shortness of breath, abdominal distension, and leg edema. What about now?
There we go. Now
There
we're
you
good.
go.
All right, so this is the story. Cirrhosis of liver, GI bleed, permanent AFib, underwent a atrial appendage occlusion in Fresno, April 9, 24, was dead, has diuretics were decreased. He presents 2 weeks later with severe shortness of breath, abdominal distension, and leg edema. So they do an exam, they don't find anything. They see he's in gross heart failure, and then they do a CT scan. Do you see
Ooh,
anything?
Oh, yikes. Yeah, the Watchman's
Yeah,
gone.
it's in the
it's in the
aorta,
aorta.
huh?
So then this is a frantic call from my ex fellow. I've embolized the Watchman device in the arch. He didn't take his diuretics. He has increased edema. Can you help me? You didn't teach me how to remove a Watchman, so I'm transferring the patient to you.
I
I love
like
it.
your
He
fellow
said,
already.
you taught me how to put it in, but not to take it out. So I'm giving it to you. Is that okay? So
That's a failure
Yeah,
there, Saibal.
so it's a fair point.
Yeah.
So what do we do now with this patient? So he appeared in. This is when and I reviewed the AI generated note, because when I say it said patient acute distress, acute heart failure. I revised the general note as cardiac exam, WNL, lungs, NAD. And what does WNL NAD usually mean? WNL means we did not look, and NAD usually means not actually done. So when you see notes like that, okay, nothing was done for this patient.
I
So
love it.
then we decided, what do we do with this patient? This is what it actually means, right? NAD. So whenever you see a note WNL, it means we did not look. So then I said, okay, this
That's
is
awesome.
the patient. Transthoracic echo and the exam. Okay. I examined this
That's an
patient.
MR.
Yep. And I look a little bit more carefully.
Oh,
Ooh,
fail. It's got a
tore
fail
something.
posterior, probably a
Yep.
P2.
That's right. So I was called frantically by the echo tech that the patient's got endocarditis. And I said,
No.
this is,
That's what happens when a watchman
yes,
goes through there, right?
Yeah. How big was the
huh?
watchman, by the way? How big was the
27.
watchman? 27. Okay.
So
It's not bad.
then I said, oh my God, now I know what the problem with this patient is. And this is the MR. And you can see something very important, that the left atrium is not that big. And you can see the pulmonary veins are
Yeah.
completely reversed. And that's usually a sign that this
Yep.
is acute severe MR.
Yep.
Sure.
So I realized this is acute severe MR, most likely not from endocarditis, but thanks to the watchman, which basically broke the cords and just went up. So we went, of course, removable. This was a plan. Anyway, what would people do? How would you remove them?
Yeah, well, I mean, you got to get the Watchman out
Okay.
first, because that's causing an increase in
Okay.
afterload, which is not going to help his mitral
Right.
regurgitation. So, you'd probably have to flip it and grab it with the Raptor or that Sterix that everybody use. And then clip them probably.
I would do the MitraClip and send them back to your fellow.
So anyway, so I decided, what would you do, Devi?
I definitely take the watchman out
How
first,
would you
and then
take
I'll
the
call you
watchman
to
out?
come fix the microphone. Oh, how will I take it out? I guess it depends on. Can you show that picture of the arch where it was? I think my worry would be where on the arch it is, whether I put a sentinel or not. If it's past the carotids, I would not. Okay, so that one, I definitely think about a sentinel for sure, if possible. Have at least a 20 French sheath in the artery, and go with the raptor, flip it around, and pull it in.
So,
Yep.
and you would send the Raptor directly to the 1820 French sheet. Is that what you're saying?
Yeah, I mean if you are using the thing is, if you're using, I mean, I like to use, again, back to
Yeah.
deflectable sheets. I like to use deflectable sheets, but none of these deflectable sheets are long enough to get up there. At least today, we do have a deflectable sheet that we use for VTs now. That is, and I'm running out of the name. It starts with a V, but it is a deflectable sheet that it's a long sheet that gets all the way around the arch. It's kind of soft, that you could put through the gore sheet, and kind of deflect down and have a little more precise motion over the appendage. Because it's in, I mean, with the Raptor, you can catch anything, right, on that, but you want to make sure you don't rip the fabric. Sometimes it's better to go through the struts and catch it from inside out. Like, that's how I usually take it out, as I go, especially sitting like this. I'll go through the back end of the struts. It's almost like pulling your pens inside out. So whatever thrombus is inside of it, you catch that as well.
So the first thing I looked at it, I said, look, if the device was sitting with the anchors pointing backwards, that's a bad thing, correct? You don't want that to happen. If the soft device, but you can see the device is on the side. It's now on the side. It's
Yep.
not, the proximal and distal are not pointing downwards and backwards, correct? So the anchors are
Yeah.
around and not touching the walls, or at least not touching the superior inferior wall. They're touching some walls. So I thought that was good. So I said, I'm not going to mess around by trying to flip this device, because I don't think I'll be able to flip it. And I said, I just want to grab it anywhere. The second thing is, I used only an 18 French sheath, a cook sheath, which goes up to 40 centimeters. So went up to descending order. But through that, I advanced a 12 French steerable sheath, and that is used for cryoablation, the same thing that you use. And that's 90
Yep. Yep.
centimeters. So 90 centimeters usually will
Yep.
go up till the arch completely, and through that I advanced the Raptor. I used it's basically, so 18 French Medtronic Centron sheet, 12 French steerable Steris slash Medtronic sheet, and through that I advanced the rat tooth forceps. I used the rat tooth. I didn't use the Raptor. The rat tooth is slightly different. It's slightly less strong. It's 8 millimeters long grabs, and then you can just use
I think
fluoro, two views, AP and sorry, RAO and LAO, and make sure that you're on the device and not catching the wall. So I got one looking forward and one from the RAO to make sure that you're in the middle of the vessel. And then all I do is just grab any part of the device. It really doesn't matter where you grab. So that's the pictorial angiogram. You can see that it's lying on the side, right? And it's over the
Mm-hmm.
carotid. So there's no way I could do a cerebral protection. So I just said, I'm just going to grab it. And then you can see over here, I didn't take all the pictures, but you can see over here, when you pull the device into a 12 French steerable sheath, you can see that the device is already squeezed down, right? And then over here, I basically pull the 12 French sheath device right through the 18 French easily.
Oh, there we go.
And then you
Beautiful.
came out,
That's
and once you're
pause.
18 French, and I closed it. And then once that was done, then I focused on that was the device. You can see it was caught in the corner. And look at that. The 12 French itself, mangles it into a smaller device, and then you can pull that in through an 18 French. And if you're on the side, see, I caught it basically on the side. And once you grab it, usually it doesn't come out.
Yeah, I think the working length of that cryo sheath is only
Yes.
65. So even though it is a 90 sheath, the work, because of the handle is long enough that the working length is only 65. So you have to be able to maneuver that wrapped around. So as long as the distance is okay,
Well,
in a shorter person, I
I
think
managed
it's
to bring the Raptor sheet, the steerage sheet close to the device.
close to the device. Yeah, I mean, as long
Yes.
as you can get something through, it's fine. I think it's almost a sheath and
Right.
sheath, but that, I mean, that's pretty much the only way. There are times when we have actually cut the steerable, the 12 French. We'll bevel it, but then you lose your
Yes.
steerability a little bit. But if you just bevel it just enough, you could make it a
Yeah,
little
and
bit
then
more
you can
bigger.
pull a little bit in, and it just makes it smaller, and then it just comes out through an 18. An 18 sheet is very.
Yep.
All devices will go through an 18 French sheet. I've tested it actually.
Yeah, that's great. So it looks like too, once you've compressed it there on the
Yes.
right, now you've got the anchors
Yes.
are inside probably. They're not exposed anymore. So now you can probably just drag
Yes.
that down to your
And then I
your
could
bigger
drag it down the
piece. So
descending without causing much of damage, and it just popped through the 18 French.
That's great.
yeah,
And then,
that's
It
good
is
to know.
interesting
Fortunately, I
that
haven't been in that
no, it's
situation,
good to
but
know. I mean,
Oh,
these things
wow.
can happen to anybody, and you need to know these. And then I look, obviously,
it is interesting that it costs a flail, though. Like, we talk about devices
yeah.
tumbling through, but the fact that it
Now look
costs a
at this.
flail, that's
3
super
flail
interesting.
segments. Look at that.
Yeah,
There, one in
wow.
the medial,
Wow.
middle, and things. So this became a problem to me to understand how I should fix this. So I knew there were 3 flail segments, and you can see if you look at the 3D, um, you can see the 3 flail segments. Actually, you can see that the medial part of P2.
Oh,
There's
yeah.
a bit of P3, and there's a jet, but it's localized here around the flail segments. So I knew that I would put one clip there for sure on the medial part of A2P2. So I took, I think this was obviously a Hail Mary edge to edge repair. And then we went in with an XTW. And then we grabbed,
Wow.
that's great already.
and then we
Yeah.
went
That's remarkable. That's a one clip
one clip
result.
done.
Wow.
And then I said, I'm not happy with that. So I said, I'll put a second clip. And I actually went to trace them out.
That's amazing. Wow.
That's great. So, it must have gotten caught because it didn't look like it didn't lacerate the leaflet. It really probably just got caught in the cords and tore cords. So the anchors must have just got caught down there. But that's a great case.
And this is what it did.
Wow.
She had significant improvement of symptoms. Like, Richard, can I call you back? I'm going to call you back, Richard. Yeah. So the patient had a significant improvement in symptoms. His edema dramatically decreased. And he couldn't be bothered whether the watchman was done or not. And by the way, the only thing I didn't do is I didn't put another watchman in. Which I should have. I was already tired and exhausted.
He was done with the watchman.
No, but I thought that, now he'll remodel his left atrium. He's cirrhotic liver. His INR was 3 when I was doing the procedure. So
Oh, man.
I said maybe he doesn't need anything in there.
Let me guess. It was on a Friday
This is
afternoon.
on a Friday
too,
afternoon.
Oh, my gosh. Wow. That is a remarkable case. I love it.
All right, guys. Well, I think, Joe, we've got it's about time. Unfortunately, our ringleader, Tom, did not make it today. He must have been stuck in a crazy case. But this could be the first ever SWAC without Tom present. So
Yeah. Well, Saibal, Devi, thank you guys so much for joining us.
thank you,
Devi,
guys.
especially from Australia, we really appreciate you tuning in here, and thanks so much, guys. We really appreciate it. Those are great cases.
Thank you.
Yeah.
All right. Have a great day.
Thank you, guys.
Talk to you soon.